To all of you. I am Dr. Shobna Marathe, Medical Affairs Manager with Abbott PPD. It is a pleasure and honor to welcome you all to this conference on neuro-AIDS by the HIV Medicine Association of India. Cognitive disorders, myelopathy and sensory neuropathies associated with HIV are the most common disorders in patients with HIV/AIDS. The effects of HIV on the nervous system are the topic of interest to investigators and clinicians focused on HIV worldwide. This conference offers a platform for scientific discussion and knowledge upgrade on this important aspect of neuro-AIDS. I welcome you all and now request Dr. Atul Patel to please take the session forward. Dr. Atul Patel is consultant physician in infectious diseases and HIV medicine at the ID Clinic, Vedanta Institute of Medical Sciences, and a director of the Department of Infectious Diseases at Sterling Hospital, Ahmedabad. He is also a visiting assistant professor in medicine, Division of Infectious Diseases at the University of South Florida, USA. He has a special interest in HIV/TB co-infections, and his group is running an effective prevention program for mother-to-child transmission at his ID clinic at Ahmedabad. Sir, I request you to kindly take this session forward.
Yeah, good morning everyone, and on behalf of HIV/MAI, I would like to welcome you all for this monothematic conference on neurocognitive disorders in HIV-infected patients. Before I introduce our two guest speakers today, I would like to make two announcements. The number one announcement is that the HIV/MAI is going to have an online training course in HIV medicines with collaboration with Johns Hopkins University, Baltimore, USA, and this course will probably start from mid of January 2014. So those who are interested to get this online HIV medicine course, please visit HIV/MAI website for the latest updates and for the forms for enrollment in this HIV medicine training course. And the second announcement is that the annual conference of HIV/MAI would be in November at New Delhi, and this year, BIVA is jointly organizing, BIVA is having active collaboration with HIV/MAI for HIV/MAI annual conference. So with these two announcements, let me introduce our guest speaker, Dr. Ed Wilkins. In your invitations, you must have read about him that he is the infectious disease doctor from the North Manchester General Hospital, and he is also a clinical director in HIV research unit at the North Manchester General Hospital. He is actively involved in the various guidelines published by the BIVA. He is a very key member of the BIVA guideline committee, and he has also published more than 75 research papers in the different subjects in HIV medicine. And today he will be talking about the important aspect in the HIV, that is neurocognitive abnormalities. Why this is important? Because there is a great survival benefit with anti-HIV medications to these infected patients, and they survive near normal life, right? So because of this prolonged survival with the highly active anti-HIV medications, we have witnessed that all opportunistic infections in HIV has gone down tremendously in the era of heart. But the neurocognitive decline, the prevalence has gone down, but the incidence is rising. And why this incidence is rising, probably we'll discuss in today's the monothematic conference. And we need to address the neurocognitive abnormalities in HIV-infected patients to provide them a good quality of life. So probably we'll have a very good discussion after Dr. Wilkins' lecture. So we are, waiting for your talk. And our local hero, Dr. Ashish Atre, he is a radiologist from Pune, and I heard a lot about Ashish from Dr. Sanjay Pujari. Actually, he is a die-hard fan of Ashish. So whenever he discussed some radiological like MRI and CT images, he just, bottom line, Dr. Ashish says this is this. So the matter ends. So we look forward to have the variety of neuroimaging problems in how to interpret the neuroimaging things in HIV-infected patients from Dr. Ashish. So let me invite first Dr. Ashish for his neuroradiology in HIV infected patients. Ashish, please.
Good morning, everybody. Thanks, Dr. Atul Patel, for those kind words of introduction. And actually, I am probably a misfit in this gathering because I am not a clinician and purely a radiologist, and that too a neuroradiologist. But I would try and make sense of the given opportunity and show you as many images as possible, so that at the end of it, at least some routinely seen pathologies one can confidently diagnose or at least suspect on imaging. And secondly, we can also look at the differential diagnostic possibilities that exist when you see a particular imaging pattern. So to begin with, we know that during seroconversion there are several neurological manifestations that a patient can suffer from. But most of the times these are not the patients that come for imaging, because most of these problems are clinical and do not have any imaging changes on either CT scan or MRI. But in late HIV infection is where neuroradiologist plays a big role in helping clinicians to diagnose conditions and probably helping them to monitor the response to treatment. So we group these conditions as features which are directly related to the neurotropic effect of HIV, and amongst this is of course HIV encephalopathy, which we are going to discuss in detail, vacuolating myelopathy, sensory motor neuropathy, which does not have much of radiological manifestations, and HIV vasculitis, which is playing we are seeing more and more number of cases of HIV vasculitis. We do not know at this point whether they are directly related to HIV infection or due to the opportunistic infection. We will discuss about this in detail. Then of course we will talk about opportunistic infections and opportunistic neoplasm, and then we will see some effects of drug-induced complications like Wernicke's encephalopathy, etc. Subsequently. So when we look at the AIDS dementia complex, we know that it is a clinical syndrome of altered mentation, cognitive deficit. One can have meningism and dementia. Now, why this particular syndrome arises and why it follows a typical course is something which is still not very clear. But we know that HIV directly involves the neurons and the glial cells, induces an inflammatory response. The inflammatory response is followed by phagocytic infiltration of the tissue, which eventually leads to death of neurons and glial cells. That is the natural history of this direct neurotrophic effect of HIV virus. What it presents on imaging is the atrophy, which is a late manifestation of this disease process, or it can have white matter changes because of the predominant involvement of subcortical and periventricular white matter, or it could have both. So what gets involved first? Is it the gray matter or is it the white matter? Frankly, we do not know. One could have extensive gray matter atrophy without any significant white matter involvement, or there could be so much of white matter involvement but hardly any gray matter atrophy. And why is there such a difference in the manifestation of HIV encephalopathy? To this point, we do not know. And does this have any definite clinical impact? That also is still not clear. People who have more of cortical atrophy are known to present earlier clinically than those who have more of white matter abnormalities. For example, this patient has extensive white matter changes which are almost symmetrically distributed, involving the periventricular white matter. There is relative preservation of all this subcortical white matter which is located beneath the cortex. But if you look at it, there is hardly any gray matter atrophy. This brain looks perfectly non-atrophic for a 40-odd-year-old man. So this is basically white matter involvement without much of gray matter atrophy. As against that, look at this patient. There are hardly any white matter changes, but this is an 18-year-old boy, and what his brain looks like is definitely of a 50-year-old normal person. Or it could be a more usual finding where we have a combination of gray matter plus white matter involvement. A lot of gray matter atrophy. Also associated is white matter signal changes, which are again predominantly periventricular with sparing of subcortical U fibers. So the white matter involvement, we have to distinguish it from another white matter condition which is very common in HIV, that is PML. So how do we differentiate it? The white matter involvement in HIV encephalopathy is essentially bilateral. It is almost always nearly symmetrical as against PML, which is classically asymmetrical. This involves periventricular white matter as against PML, which is predominantly subcortical white matter, and there is no enhancement in either of these conditions. Do you get infratentorial lesions with HIV encephalopathy? It was largely believed that if you have a supratentorial white matter lesion and you also have an infratentorial involvement, then HIV encephalopathy is very unlikely. That was a belief, say 2 or 3 years before. But today we see a lot of posterior fossa white matter involvement, which can be symmetrical or asymmetrical, as in this case the dorsal part of the pons is involved, the middle cerebellar peduncle is involved, and the deep cerebellar white matter is involved. And this patient also had extensive supratentorial white matter affection. So involvement of posterior fossa white matter is not sort of not an unknown thing in HIV encephalopathy, but only caveat is that if you get only posterior fossa white matter involvement without any supratentorial affection, then it is unlikely to be HIV encephalopathy, and PML is a more likely possibility. So posterior fossa white matter involvement is not very common. It is uncommon, but it is not very rare. What about response to combination antiretroviral therapy? We talk about it a lot on clinical response evaluation, and patients are known to improve with highly active antiretroviral treatment. But as far as my experience go, I have hardly seen any change in either cortical atrophy, which we do not expect to come back, but at least change in white matter involvement reduction on MR, I have hardly ever seen. This is the only patient which I have which has shown some response, though clinically this patient was much better with starting off antiretroviral treatment. But on MR imaging, we see some of reversal of white matter signal changes on post-treatment, but largely the changes have remained nearly the same. What is the role of other modalities in diagnosing AIDS dementia complex or HIV encephalopathy? And a lot of modalities have a significant role to play, especially SPECT and MR perfusion. Now there is a good article which has been published lately describing the role of all these modalities. As far as my experience goes, we have not really done neuroperfusion or DTI. We have done some work with MR spectroscopy. I do see spectroscopic changes in HIV encephalopathy, but those are already clinically proven cases of HIV encephalopathy, and imaging has been just used to sort of prove the diagnosis or substantiate the clinical diagnosis, and I have not found any of these modalities, with whatever little experience I have, to be useful in diagnosing a condition. They may be useful as a research tool or for the prognostication and follow-up on treatment for the patients. Cranial neuritis is one more thing which we are seeing not very uncommonly. I have 4 or 5 patients lately seen with isolated cranial neuritis, and these patients either have localized cranial nerve palsy, or for example in this patient he had severe trigeminal neuralgia, and this could either be because of the virus leading to focal meningitis, or it is due to direct cranial nerve infiltration. But we are seeing such cranial nerve enhancement which could explain patient symptoms nowadays not very uncommonly. Another condition which is thought to be direct neurotropic effect of HIV virus is the vacuolating myelopathy. Now here in this patient we see this signal alteration which is there in the dorsal cord affecting the posterior part of the cord. What we see is this dot-like hyperintensities which are in the posterior column, typical distribution of HIV vacuolating myelopathy, which it shares with subacute combined degeneration. We hardly ever see any enhancement. SACD can have enhancement on post-contrast study, but I have not seen vacuolating myelopathy enhancing on post-contrast MR evaluation. And this is a very nice case which I had recently, which really explains why it is called vacuolating myelopathy. You really see cystic changes. They appear extremely hyperintense on these T2 weighted images and almost look like cyst, and that's why probably the name of vacuolating myelopathy, though I know it was basically based on the histological appearance of these lesions. Moving on to the angiitis, which is kind of a new entity. It has been there for last 5-6 years, but initially what we thought was that this was a typical HIV angiitis that we see in all these patients. Whenever we used to see any vascular narrowing or significant stenosis, we used to call it as HIV angiitis. But today we know that angiitis in HIV positive patients can be caused due to several etiologies, and the most common ones of course are tubercular meningitis and CMV are the known causes. So when we diagnose HIV angiitis, or it is also called called as primary CNS angiitis in HIV positive patients, then we have to exclude all other pathologies, and it is a diagnosis of exclusion. It predominantly affects small and medium sized vessels, and how HIV virus involves vessels is because of the direct invasion of the inner elastic lamina, leading to endothelial proliferation, narrowing, and subsequent thrombus and infarcts, or it could be due to clogging of the vasa vasorum, which are supplying the medium sized arteries and leading to the effects. Lenticulostriate arteries are the most commonly affected vessels, and this is the 4 or 5 cases. This was the most classical thing which we have seen. It is almost looks like involvement of the terminal internal carotid artery, the proximal middle cerebral artery, as well as the anterior cerebral arteries. There are areas of focal narrowing and dilatation. This is a typical appearance of the primary CNS angiitis or HIV associated angiitis. This patient also had a focalized subarachnoid hemorrhage in here, which is seen as dark area on these gradient echo images. Now this is an interesting case where patient had suffered from right-sided hemiplegia. He had a focal infarct in the left centrum semiovale. This was not an acute infarct but a subacute infarct, but his MR angiography showed this dilatation of the terminal ICA, which is a fusiform aneurysm, and probably had thrown embolus from this aneurysm leading to the centrum semiovale infarct. We did not know whether this was a direct effect of HIV angiitis with weakening of the vessel wall leading to aneurysm, or it was indeed a congenital or acquired unrelated condition to HIV with associated infarct. Moving on to the second group of condition, which is opportunistic infection. I may be interrupted any time during my talk, and let's have it as an informal discussion during any time, and we can interrupt and tell me to stop whenever you are bored. So all 3 conditions, yeah.
I have one question.
Yes.
Can you go back to your HIV angiitis? The posterior circulation, and you are showing some narrowing and some dilatation here. How confident you are to say that this is primarily related to the HIV angiitis and it is not something else?
Oh, I am not at all confident. As I said, the diagnosis is essentially based on exclusion, where we have ruled out that this is non-tubercular, non-CMV. There is no opportunistic infection causing this vasculitis. Then we are saying that it is primary CNS angiitis related to HIV.
Right. The reason why I ask this question is that, like, I would like to have Wilkins' input also, because like varicella zoster is known to produces the vasculitis into the posterior circulations and produces the narrowing, some aneurysms, and the patient suffers varicella zoster related vasculitis, especially in immunocompromised host. It includes post-transplant patients as well as the HIV infected patients. And if you look at the varicella zoster vasculitis, because this is a potential case of vis-a-vis vasculitis in HIV infected patients. Can I have comments from you?
Well, thank you very much. The cases we see are nearly always tuberculous. And so I don't know if you can really distinguish what is what unless you've got a post-treatment of whatever it is. So if you're treating HIV and you've got another angiogram showing that the angiitis has actually improved, then I suppose one could say that it is related to the HIV. But with VZV, without diagnosing VZV, by PCR or various clinical signs of skin infection or VZV in the CSF, then I think it's difficult. But yeah, VZV, CMV we don't see very often. Most of it is tubercular. I don't think that's answered your question, but I don't think, from radiologically, I don't suppose you can tell what it is.
We cannot. Only difference in the VZV vasculitis and the primary CNS angiitis is that VZV tends to be monovascular more often than multivascular. So if you see a single vessel which has a focal narrowing, you can suspect that it is VZV vasculitis as against HIV angiitis. HIV angiitis tends to affect multiple vessels. As you see, it is affecting the ICA, MCA, ACA. That is not a typical pattern of VZV. In the same go, if you ask me that can you not see it in VZV, I would say no, you definitely can see it in VZV, and we would call it HIV angiitis only if you have excluded VZV and tuberculosis by serology and CSF analysis.
Yeah, because this patient requires lots of workup to rule out so many things.
Absolutely.
But probably VZV has predilection for the posterior circulation, and that is very characteristic compared to the supratentorial.
Right. If you have only posterior circulation involvement without supratentorial affection, VZV comes high on the differential diagnostic list. Yes.
Can I ask, when you're, oops, I'm still on, to apologise. When you're treating VZV or CMV, have you had the steroids as well as giving the antibiotic?
Yeah, this is a very good question, because I mean, this question raised when we published first case of VZV vasculitis in HIV infected patient who presented as iris. In fact, in that patient we have not used steroids, but steroids can be used very safely, especially when the VZV vasculitis is as a part of the iris phenomena, like the case that we have presented. But yes, like in vasculitis, like tuberculous vasculitis, CMV or VZV, you can combine very safely the steroids along with appropriate antiviral therapy.
Yeah, but the duration of therapy should be very carefully guarded. Steroids should not be overextended also, because that can have a counterproductive effect. So one should give it for a particular period. It should not be very prolonged.
No, it is not a prolonged therapy.
And just to check, you didn't stop at heart. You continue with the antiretroviral therapy.
Yeah, we continue antiretroviral therapy.
So moving further, now we will look at the second group of conditions, and that is the opportunistic infection, and we would address progressive multifocal leukoencephalopathy MR appearances first. Today, whenever I talk about HIV or any other imaging, a lot of people have questions as to whether we should be using CT or MR for evaluation of neuroradiological manifestations. Today I feel with the availability of MR being so widespread, I do not see any role of CT. There is of course a small caveat to it, to which I will come later when we discuss about pediatric AIDS. So most of my imaging is MR. There is hardly any CT images that are there in my presentation. We will let go this etiology and stuff, but we will look at the MR appearances of PML. Now this is sort of, I would just like to begin with showing something which is slightly atypical, in the sense that PML we know involves predominantly the subcortical white matter. So we see the involvement of subcortical white matter. When it is advanced, it goes towards the ventricular margin and also involves the periventricular white matter. But here the involvement is predominantly of frontal lobes, which is not a very typical site of PML, though it can be involved. The more typical appearances are of course this, that you have a subcortical white matter involvement in the parietal or occipital region, but in this patient it is unilateral. There is hardly any involvement on the contralateral side, again an atypical feature. But this is a more typical appearance of PML, where you have bilateral but characteristically asymmetrical involvement, with involvement of subcortical white matter more than the periventricular region. How do you know that the subcortical white matter is more involved or involved earlier based on the imaging? Is because if you see on these T2 weighted images, the hyperintensity or brightness that you see of the subcortical white matter is much more than what you are seeing in the periventricular area. So this area is more gliotic as compared to the periventricular region, and that's why the subcortical white matter is the one which is first involved and more involved as compared to the periventricular area. Though we know as the disease progresses, there is going to be progressive involvement of more of subcortical white matter, and ultimately it is going to extend to periventricular region as well. Can PML enhance? Characteristically no, there is hardly ever any enhancement in PML, but we do get occasional case of enhancement in PML, and presence of enhancement does not exclude the diagnosis of PML, is what I would say. Can you get posterior fossa lesions? As I said, yes, they are more common than we see in HIV encephalopathy. For example, this patient had solitary involvement of posterior fossa, middle cerebral peduncle and the cerebellar white matter. There were no supratentorial lesions. He had grey matter atrophy, which probably could be explained by HIV encephalopathy, but he had no white matter involvement at all in the supratentorial region, only posterior fossa white matter. If you see only posterior fossa solitary white matter involvement, then it is more likely to be PML. Of course, there are clinical differentiation where you are going to have a focal neurological deficit, which is more commonly seen with PML as against cognitive deficit, which is a hallmark of HIV encephalopathy.
I just have a question.
Yeah.
You said that usually PML is non-enhanced.
Yes.
It's not enhanced. And in very few cases you have seen the enhancement. Have you clinically
Yes, I will. Yeah, I will address that issue separately as we go on. Yeah. Does spectroscopy have any role? We are using newer and newer modalities to come to a specific diagnosis. As far as PML goes, I am skeptical. We do it almost always to exclude things. For example, if I see some mass effect associated with PML, which is again characteristically never seen, but if I am seeing something, then I would use spectroscopy to sort of rule out other conditions, but spectroscopy does not confirm the diagnosis of PML. It is essentially a morphological based diagnosis of subcortical white matter involvement, a typical clinical presentation, lack of enhancement and lack of mass effect. Spectroscopy can show this finding of elevated choline, which is a non-specific thing and does not make you diagnose, does not prove your diagnosis. What about response to antiretroviral treatment? Now, I have seen a lot of patients images responding to treatment, in the sense their lesions disappearing. This is one such patient. This has, and this I have almost always seen with posterior fossa lesions. I have hardly ever seen supratentorial lesions showing that significant response, probably because they are too large when the patients come to us. But such small infratentorial lesion, for example, this patient who had presented with acute onset of right-sided 6th and 7th nerve palsy, he has a focal lesion in the dorsal pons, which is also bright on this sagittal flare images. This, after starting of antiretroviral treatment, this is a 4-month later scan. We do not see any residue of this lesion. Now, somebody could argue that this has become gliotic and that's why it is not seen, but we almost always see area of gliosis as persistent hyperintensity on flare images. So this is, and the patient of course has clinically also responded. So both things put together, this is probably indicates response to antiretroviral treatment. Now coming to the other question which was asked, this is a 32-year-old man presenting with altered consciousness and altered behavior. We see a large area of white matter signal abnormality which is affecting both cerebral hemispheres, but predominantly involving right to some extent frontal, temporal, parietal and occipital area. There is a lot of mass effect on the ventricle. In fact, there is midline shift. You can see on the sorry, flare images the amount of signal abnormality that is there in this cerebral hemisphere. But again, this lesion is involving predominantly the white matter. The overlying gray matter is almost all preserved. What about post-contrast study? This is the non-contrast T1. Post-contrast is showing this extensive areas of ill-defined enhancement. You can compare it with the contralateral side. So this area is definitely enhancing. There is so much of mass effect. His MR was, at this point, I did not know what this was. This was in the middle of the night, and Sanjay has this habit of sending me images at the middle of the night on WhatsApp and saying, what do you think? I said, I don't think at night. So, but that time I said, I don't know what this is. We'll see about it tomorrow. And next day, the patient comes back to me with his old films, which were there already there in the center. And he had these lesions on the MR done 4 months back. These lesions are almost in the similar distribution. That time there is no mass effect. There was no contrast scan was done at that time. So what is it? If we look at in clinical perspective or in the patient's history of starting antiretroviral therapy in this intervening period, then the things fall in place, and this is definitely PML iris, and it had presented with those acute onset of mass effect, edema, midline shift and enhancement. So yes, history of antiretroviral treatment when we see PML enhancing is very important, and we see it with PML iris very commonly. Yes.
Now questions to Dr. Wilkins. Oh, yeah. Do you see iris in PML after 4 months of starting ART? 4 months.
Well,
It's 120 days.
PML is, I mean, the last 3 cases I've seen have been patients who've actually presented having started antiretroviral therapy, and that's when the PML has actually presented. And usually the cases I've seen, they have peripheral enhancement around the area that you've previously seen as opposed to the one that you showed. And that is, in the majority of patients, they now do reasonably well, but with no neurological improvement. As you can see here, with a lot of atrophy, then, you know, as PML becomes burnt out as the CD4 count increases. But it's usually around the edge of where you have PML that the enhancement patients I've seen seems to occur.
And the mass effect is also, I mean, it's a significant mass effect, like, I mean, I have not seen, so, I mean, could it be something else apart from PML iris after 4 months of starting ART?
If I may go back to the images, I would go the other way around in saying that is there any differential diagnosis for these images? In the sense, images which were done 4 months back, can we think about, that's how I went about it, can we think about any differential diagnosis for the lesions that we are seeing? And that time I thought, I had reported at PML very clearly then, and looking back or having a second view of it, I could not come or think about any other pathology that time, but of course it is open for debate.
You know, because like why I'm questioning this, I mean, because this is, I mean, good clinical discussion. Why I'm questioning, because the PML generally occurs when CD4 count is very low, generally less than 100 or so, right? And once you put them on anti-HIV medication, which is very effective, the iris generally comes earlier rather than waiting for a 4 months time. So most of these patients, you may get iris within 3 to 6 weeks time, or it could be earlier, because you are starting him on effective anti-HIV medications, especially when you are using efavirenz. Like, it can rapidly bring down your viral load to very low levels. So 2-log reduction is not uncommon to see in 2 to 3 weeks time. Many patients may achieve undetectable also. So with rapid reduction in viral load, we expect PML iris to occur early rather than waiting for a 4 months time. And most of the iris, as Dr. Wilkins rightly described, that it is a peripheral enhancement.
Right.
And mass effect, I'm not sure, but I have not read about it. So probably with this patient, like once this patient stabilized by giving edema reducing measures, like after giving dexamethasone and the mannitol and other things, I would definitely do a biopsy and just to find out what it could be.
Right. So this is the same patient's.
Do we continue the ART, sir?
Yeah, I mean, this is a big question. I think, I mean, let me have an opinion from the overseas expert.
I think with RS you never stop the ART. I think it doesn't matter where you have the RS, I think you have to continue. If you stop the ART,
I'll be
you're basically
taking this
giving
case,
in.
I'll be taking this case, so maybe we can have the discussion on iris at that time. Because I have a case presentation and we'll be covering most of these points at that time. So I think let's move ahead, if you don't mind.
Okay, that patient underwent a biopsy, and as always, or rather I should not say as always, but as on many occasions, the biopsy just showed demyelination and nothing more. So I guess PML is demyelination, you don't see anything more in PML, but this is a subsequent follow-up MR which shows extensive atrophy of the right cerebral hemisphere. All the mass effect is gone, and we also see an interesting finding of Wallerian degeneration. This is the corticospinal tract, the parieto-pontine tract, and we see that this ipsilateral half of the midbrain has become atrophic, and there is a focal area of hyperintensity in the area of corticospinal tract. Now this is also a well described finding that PML can have Wallerian degeneration. This is also, there are many published papers, but each are of 3 or 4 cases. So there is not a big series in any of these papers, but it is a published fact. Moving on to the, yeah.
I mean, that's a picture. I don't know anywhere near as much as you do about the radiological appearances, but that's the classic picture you see with somebody who's got a CD4 count above 200, that's completely burnt out, PML, and a lot of neurological disability. So getting that original diagnosis, I thought it was PML.
I don't know what is the general consensus about biopsying these patients is, but to be frank, our mine and Sanjay's yield of biopsies has not been great.
Well, again, with PML it's changed, so I do apologise, but I was going to say with PML you just need the MR scan, you need the JC virus in the CSF, you have those two, you don't need the biopsy, because it's a
absolutely so.
Previously you needed the biopsy. But I think the trouble is with HIV low CD4 count, you sometimes find 2 diagnoses. You know, if you don't know what's going on, you suddenly find they've got TB and they've got PML. And where you're in doubt, you have to do that because you're not going to be treating the right condition. And PML, yes, we can't do very much about, but all the other conditions you can do something about. So if you have a really good neurosurgeon who's, you know, behind your shoulder waiting to go in and stick a needle in, that's fantastic, but I've never gone to any department anywhere with such a neurosurgeon before.
Right. Okay, moving on. Toxoplasmosis, of course, is probably the most common opportunistic infection, and it can come in various forms. It can have a granuloma, it can form an abscess. Predominant site of involvement is supratentorial region at the grey-white matter junctions or in deep grey nuclei or in the periventricular area. Also, this is also a common site for lymphoma associated with HIV. So there is a differential of lymphoma which needs to be considered when we are looking at lesions which are periventricular or which are involving corpus striatum predominantly. But these lesions tend to be multiple, and generally there is no meningeal enhancement associated with these lesions. Now, as far as CT, this is probably the only CT picture in my talk, we see it as a ring enhancing lesion on CT scan associated with perilesional edema. It could be hyperdense because of presence of blood degradation products, which is a characteristic features of Toxoplasma granuloma, but the ring enhancement is almost like any other granuloma. On MR, the lesions can follow variable signal intensity, and on T1 it is nearly iso to hypo, but it is hyper intense on T2. If it is already form an abscess, then the central area is extremely bright. It looks like any other abscess, and if there is blood degradation products within the lesion, then they could be bright on T1 and dark on T2 weighted images. On spectroscopy, it again may help sometimes by showing you a large lipid peak. How it helps is actually that it shows you whenever there is a differential possibility, or you're considering a possibility of lymphoma based on the imaging appearances, then spectroscopy could be useful, because Toxoplasma generally never has elevated choline as against lymphoma, which has a lot of choline in it. But if you are trying to differentiate two granulomas, tuberculomas from toxoplasmosis by spectroscopy, more often than not, both will have lipid lactate peaks, and you would not be able to differentiate between these two conditions. But there is one characteristic feature of Toxoplasma granuloma which many times sort of confidently allows you to put your finger and say that this is Toxoplasma, and that is what we are seeing here, is that this infolded margin of enhancement. You see the capsule of Toxoplasma enhancing, and then you see the membrane which is infolded within the granuloma, and which is called as a nubbin margin. Now this is a typical appearance of Toxoplasma granuloma. If I see this, I am almost always confident that this is Toxoplasma. Frankly, it doesn't really matter whether I am confident or not, because all these patients would be put on anti-Toxoplasma treatment and would be re-evaluated for response. So, but I am confident in saying that this is Toxoplasma. If I again see areas of hemorrhage like this in a periventricular granuloma, I am almost confident that this is likely to be Toxoplasma rather than any other granuloma. Of course, there is one more granuloma which can bleed like this. We'll look at it a little later. Posterior fossa lesions is a very well-known finding in Toxoplasma. The posterior fossa is not immune, but I have seen that whenever there are posterior fossa lesions, there are almost always bigger supratentorial lesions with toxoplasmosis, but not a rule anyways. About cord, this is the case which I have seen just 3 or 4 days back. This patient came with acute onset of lower limb weakness. He has this focal area of cord signal change, central area which is extremely hyperintense, surrounded by a hypointense capsule, and there is a lot of edema surrounding this focal lesion. It enhances brilliantly on post-contrast study. The central area is not enhancing, the peripheral capsule shows smooth enhancement. And this patient also incidentally had a focal lesion in the brain, so this was presumed Toxoplasma and is put on the anti-Toxoplasma treatment. I do not know follow-up because this is a recent case. But diagnosis of Toxoplasmosis is based on treatment response. Important thing is what is the time duration after which we should be doing the scan to look for treatment response. In my experience, I do with Sanjay is that if the patient is not doing good clinically, then we repeat a scan at the end of 3 weeks of treatment. If the lesion has worsened, then it is definitely not Toxoplasma, or that is what we conclude. If the lesion has remained stable, then we will continue the treatment for 6 weeks and do a repeat scan at the end of 6 weeks. If the lesion has regressed, then we are sure that it is Toxo. We have sort of decided or consented that we will not start anti-tubercular and anti-Toxoplasma treatment at the same go, even though we imaging wise are not sure of the diagnosis, we'll presume that it is toxoplasma and treat for it unless patient is really bad or is worsening on treatment. Because there is otherwise on follow-up also, there is no way of knowing whether this was indeed toxoplasma or it was a tubercular lesion which was which is responding. Important thing is again is that for how long do toxoplasma lesions continue to enhance? Because that again is an issue. Patient comes for a follow-up after say 2 months on anti-toxoplasma treatment, and they are going to receive this treatment for lifelong because the treatment is going to kill only the live organisms. So for dormant organisms, I guess they are to be treated lifelong. Am I right?
No.
Yeah. No?
Well, you don't.
No, you don't. Oh, I'm sorry about it.
Well,
So.
no, I didn't mean to be rude, contradict, but I mean, sorry, as soon as you get the CD4 count up, then you don't carry on treatment.
Okay.
And you treat for a period of time, usually 6 weeks, and then you put them on prophylaxis, secondary prophylaxis, and then when it's above 200, your CD4 count, that is the protection.
Okay.
Because a lot of people have, cysts in their brain who've just been exposed to toxoplasmosis, and then they get immunocompromised like HIV patients, and then it reactivates.
Okay, so the question was that we get so many times patients for follow-up and their lesions continue to enhance. Though they have reduced in size, but 6 weeks, 8 weeks down the line, we are still seeing lesions enhancing. So what do we do about it? It is active disease, inactive disease. You are going to continue the treatment. The answer to that, of course, is that frankly they can continue to enhance and be non-active lesions up to 6 months after completion of treatment. So just presence of enhancement does not indicate that the lesion is active, or it is not a surrogate marker for continuation of treatment, is how I understand it.
I mean, generally, like in our practice, like we are practicing since almost 20 years, like most of the toxoplasma, when we repeat a scan at 3 weeks time, there is a significant reduction, and most of them, they will disappear at the end of 6-week therapy.
Right.
But I'm not sure, like, what is the time to disappear the lesions, like, because in my practice, like, I mean, most of the lesions, I mean, when we have diagnosed toxo, it generally disappears before we start anti-HIV medications at 6 weeks.
Yeah, well, I agree with everything you said. We do a repeat scan usually at 3 weeks, and usually the one thing that we do, and you get guided just like you by people very experienced in the scan, is that the edema is settling. And if the edema is settling and we haven't used dexamethasone as part of the treatment, then we're happy just to wait. But you'll still have some legacy of the toxoplasma for 3 to 6 months, but it's obviously getting smaller. At the same time, we can do a CSF. We're doing a CSF TB PCR. We're doing a toxoplasma PCR. You look at their antibodies, and if they have no antibodies, that makes you think more about TB. So you're gathering together a lot of circumstantial evidence to point you in one direction or the other. But if there's no improvement at 3 weeks, then we would ring up our surgeons and say, look, how about getting a biopsy here? We may do a PET scan if we're worried about lymphoma, but that won't help you with toxoplasma and TB. But that distinction is probably not as common as lymphoma for us in the UK.
Persistent enhancement in toxoplasma, as Dr. Atul Patel said, we do not see it very often. The problem is when we see it, what does it mean? So whenever we have seen it that's why we have had a look at the literature, and there is a lot of literature saying that the lesion can persist to enhance up to 6 months. It's not that we have seen many enhancing after 6 weeks of treatment, but whatever 2-3 we have seen is falling in line with what the literature says, that, and it does not mean that the treatment has to be continued. It is just an inflammatory response around the granuloma that can persist to enhance up to 6 months, is what the literature says.
How much time does a tubercular abscess or tubercular granuloma, if you start treatment simultaneously of anti-toxo and AKT, how much time does a AKT, I think it takes a longer time for a tubercular lesions to disappear, and that is how we diagnose it as toxoplasma if it is gone within 3 weeks.
No, diagnostic algorithm for the toxoplasma is very straightforward.
Yeah.
Like whenever you have enhancing lesions on CT or MRI, and if patient's toxo IgG is positive, very likely that you are dealing with toxo. But what you can add to this is that, like, this is a very good diagnostic algorithm. What you can add, that you can try to look for the evidence of TB elsewhere into the body. Like you should look for the lymph nodes, you should screen the chest just to pick up any the pulmonary infiltrates for tuberculosis or the abdominal lesions. So if you are getting lymphadenopathy with evidence of necrosis, just biopsy that lymph node and try to find out the tuberculosis into the lymph node. If it is there, then very likely that the lesions that you are dealing into the central nervous system could be a tuberculosis also, or it could be combined. What Dr. Wilkins says, like, because these are the immunocompromised patients, so you can get multiple pathogens. So if you are doing a stereotactic biopsy and sending these samples for IHC, for CMV or JC, you may find the presence of JC or CMV also, along with TB and other things. So you may get multiple pathogens in a single sample also.
Now this is the one odd case or rare case that I had seen, so this is the only case I have rather. This patient had this focal lesion in the left cerebellar hemisphere which has surrounding edema. Interesting finding was that his wall of the lateral ventricle is also showing altered signal. On post-contrast study, this lesion, as expected, shows the peripheral enhancement, but so also the ventricular ependyma, which is enhancing smoothly. This patient also had spine symptoms, so his MR spine was done, and we have a ring-enhancing lesion in the cord with surrounding edema. So this patient has obviously ventriculitis, he has a focal cerebellar lesion, he has a focal cord lesion, but to top it all, he has brilliant enhancement of his chorioretinal layer. So it is asymmetrical. So putting all these things together, we thought it was cytomegalovirus which would fit in this, and there could be many ways CMV could affect. And this patient's CD4 count was I think 25 or something. So it fitted in the whole spectrum of things, and this was, at the same time, I must say this is a presumed diagnosis, unproven that it was CMV, because this is an old case of mine. As far as the HSV encephalitis goes, it tends to run, I have only seen 2 patients, it tends to run a more indolent course as compared to that we see in the immunocompetent patients who generally come with acute altered sensorium. They have markedly swollen temporal lobe. These patients tend to have little bit of signal abnormality which can be symmetrical or asymmetrical. This patient has asymmetrical abnormality of the temporal lobe, and this was in HIV positive patient in HSV encephalitis. About varicella zoster, it can involve CNS in 5 different types. It could be multifocal encephalitis, which will involve white matter. It could be just ventriculitis. It could be meningomyeloradiculitis, focal necrotizing myelitis, or vasculopathy. Now this is a patient which I failed to understand when I saw the scan for the first time. He has several areas of signal alterations which were involving white matter as well as grey matter. This was a few areas were swollen, few areas were gliotic. There was involvement of corpus callosum to some extent. Infratentorial white matter as well as the cerebral grey matter was also involved. So there was widespread lesions in the entire brain parenchyma, no enhancement at all, and we did not know what it was. So Sanjay had sent whole battery of tests, and his CSF for VZV and antibodies to that was positive. So it was presumably VZV encephalitis, to which he did not respond to treatment and ultimately died. This is a recent case. Again, he has radiculomyelitis with large area of cord signal abnormalities, swollen cord, ill-defined area of enhancement in the conus medullaris and at multiple sites in the dorsal cord, and he also has enhancement of multiple nerve roots. So this is a radiculomyelitis in a seropositive patient, and his virology also came positive. The second commonest infection to toxoplasmosis in immunocompromised patients is of course cryptococcosis, and we have CNS involvement. Commonest form is of course meningitis, where we generally do not see anything on imaging and the diagnosis is made on CSF, but we can see these dilated Furka-Robin spaces, and this we see very commonly even in normal patients. But in a seropositive patients, when I see this, I become very alert and say that this could be dilated Furka-Robin spaces due to gelatinous pseudocysts from cryptococcosis. And if this patient has headache, if he has some ventricular dilatation, if he has papilloedema, etc., or if clinical features are going in line with some kind of meningism or meningitis, then it is worthwhile looking for cryptococcal meningitis. This is how they look on T2 weighted images. They may not be so dilated, and it could be just this little bit of dilatation of Furka-Robin spaces that we see here, and this was also a proven case of cryptococcomas. They can be only seen in posterior fossa, so we should be very alert if we see them in posterior fossa like we see here, and that also is dilated Furka-Robin spaces. Most of the times we see them around basal ganglia, but seeing them here is uncommon, though not very unusual. They do not enhance characteristically, and of course the diagnosis is on CSF. Moving on to what is most commonly seen in India, that is the tuberculosis. Meningitis, of course, in HIV positive patients is a AIDS defining illness, but we can see tuberculosis in the form of granulomas, abscesses, arthritis or infection. And whenever meningitis is a clinical suspicion, I always run this sequence, which is a flare sequence post contrast, and it shows the meningeal enhancement the best, and we look for it in the sulcal spaces. For example, sulcus should appear like this dark. If you see that sulcus is obliterated on this particular sequence and you cannot differentiate the sulcus from grey matter, then there is likelihood of meningitis. More typically, of course, or easy thing to see is such enhancing exudates. We used to believe that enhancing exudates in basal cisterns is hallmark of tuberculosis. I would say that in seropositive patients, we see these enhancing exudates almost anywhere and everywhere. And many times, basal cisterns are preserved. There is no enhancement there, but we see it in the cortical sulci, in the parietal or occipital region. And as we would say that in an immunocompetent patient, that this is unlikely to be COX. It is more likely to be a pneumococcal meningitis or something like that. In immunocompromised patient or HIV positive patients, enhancement like this without any enhancement of basal cistern does not exclude tuberculosis. In fact, we see it more commonly with tuberculosis than with any other meningitis in our practice. Focal cerebritis like this is also a hallmark of tuberculosis. We see enhancement which is meningeal, associated with lot of grey matter swelling, white matter edema, and this also can enhance, but the enhancement is more of leptomeninges rather than the brain parenchyma. Multiple granulomas like this, I in fact did not know that this patient was seropositive. I had reported this as neurocysticercosis. And because there were too many of them scattered everywhere, but of course there were some lesions which were dark on T2 that should have alerted me, but whenever I see so many lesions in brain and I do not know that this patient is immunocompromised, then I would still probably call it neurocysticercosis. But as I would have it, there were multiple lung lesions, so this patient had miliary tuberculosis. So obviously these intracranial lesions, and he was seropositive, are going to be tuberculomas, and this is his follow-up scan on anti-tubercular treatment. Most of the lesions have disappeared. Edema around many of them has completely vanished. The number has gone down. So this is these were multiple tuberculomas. What about tubercular abscesses? We see this area of which is centrally hyperintense. This is centrally hyperintense with a well-defined capsule, lot of edema. It is showing a peripheral enhancement. There is associated enhancement of the pachymeninges, and in fact the disease has involved the skull as well and has formed a small abscess beneath the scalp. So this is what we characteristically call as Pott's puffy tumor. The most characteristic imaging, of course, for diagnosing an abscess is the diffusion weighted MR. If you see this diffusion restriction, that means it is bright on diffusion and dark on its corresponding ADC maps in a ring enhancing lesion, this is a typical appearance of an abscess. Arthritis like this, which is affecting multiple cranial vessels, and you have an associated infarct with leptomeningeal enhancement, is typical of tuberculosis. And involvement of spine is seen in the form of, we see it all the time in thoracic and lumbar spine in the form of altered marrow signal and associated paravertebral soft tissue, but you can also get involvement of atlantoaxial joint with presence of pre-atlantal soft tissue, which is enhancing on this contrast enhanced MR study, and there is associated enhancement of dura of the spinal cord as well. What about neurosyphilis? My experience is limited. We have seen only 2 cases which were biopsy proven. I am just sharing one such case with you. This patient had this large heterogeneous lesion with multiple areas of T1 shortening in the left temporal lobe, and this had a lot of mass effect around it. It enhanced. We did not know what the diagnosis was, so obviously this patient underwent biopsy, and this patient was VDRL positive. We should have thought about syphilitic gamma, especially because we did not know what it was, but this patient underwent a biopsy, and this turned out to be syphilitic gamma. If you see such lesions in a seropositive patients which are hemorrhagic, they are hyperdense on plain CT scan. There are obviously many granulomas, and we did not do MR in this patient because if you see this, it is quite typical. And quite typical of what? Can this be toxo? Yes, it can be toxo, but toxos don't bleed like this. They have little bit of blood here and there, but all the lesions cannot bleed like this. This is more typically seen with aspergillus because it is an angio-invasive fungus. It tends to bleed profusely, and most of the aspergillus lesions, or many of the aspergillus lesions rather, tend to be hemorrhagic. So this is a typical appearance of aspergillosis. Moving on to lymphoma. Now lymphoma looks slightly different in seropositive patients as compared to immunocompetent patients, in the sense that it tends to be periventricular. That is also true about immunocompetent patients, but lymphoma in HIV positive patient tends to have an areas of necrosis and peripheral enhancement, making them look like granulomas. While the lesions in immunocompetent patients more are entirely solid, they enhance homogeneously, and there granuloma is never a differential. We are saying that it could be glioblastoma or lymphoma, while here we are saying that it could be toxoplasma or lymphoma. That is the difference between HIV associated lymphoma and lymphoma in an immunocompetent patient. Now this is a patient this is a focal area of signal abnormality with surrounding edema in the periventricular distribution. The characteristic feature of lymphoma is that it tends to be dark on T2 weighted images, while an abscess or a granuloma is extremely bright on T2. Because of the high cellularity of lymphoma, it is also very bright on diffusion weighted MR images and is dark on ADC maps. It enhances brilliantly. This is a solid lesion which is enhancing, and here is where spectroscopy really helps us in saying that there is a large choline peak, and in a solid enhancing periventricular lesion with a patient who is HIV positive, I think all features are falling in line with diagnosis of lymphoma. We have seen this. Lymphoma, remember, can be multifocal, and presence of multiple enhancing lesions does not exclude lymphoma, as in this patient. This patient was seropositive, this was HIV positive as well as VDRL positive. This had multiple areas of signal alteration which were periventricular. There was also posterior foci involvement. This patient was treated, presuming that this could be toxoplasmosis. This patient was on anti-toxoplasma treatment, did not respond, and that's when he came to us for scan. We have these several areas of enhancement, and we had to differentiate or say what it is. So we did all the advanced modalities, and this is MR perfusion scan, and it shows that this entire area of signal abnormality is having extremely high perfusion. And spectroscopy also reveals that there is a large choline peak with reduced Na and creatinine. All put together, this was a lymphoma. Patient did not respond to treatment. His CSF was done, which was positive for atypical cells, and because he had extensive leptomeningeal affection as well, so his CSF was going to be positive anyways, did not respond and died in 3 weeks' time. So how do we differentiate lymphoma from toxoplasmosis? This is a working chart, but I rely on two things. One is presence of blood degradation products and spectroscopic abnormality showing me presence of choline as against a prominent lipid lactate peak in toxo. Another feature which helps differentiating toxo from lymphoma is this extension along the ependymal lining, which is a typical feature of a malignant disease process, and we do not see it with toxoplasmosis. Spinal lymphoma, it forms a similar solid enhancing lesion, but there is a marrow abnormality which we commonly see in seropositive patients. That is, many patients who come for spinal evaluation have dark vertebrae on both T1 and T2. There is no fatty marrow in their vertebrae. And initially we used to call them pathological, not knowing what it is, but we know that they do not enhance, and this signal abnormality is postulated to be due to excessive iron deposition, because these patients are anemic and they many times receive a lot of iron supplements, and this is presumed to be due to iron overload, this signal abnormalities. What about pediatric population? If I'm overshooting my time, please let me know. We can stop any time. Yeah. Okay? So we can stop here. There's no problem.
I realise you have to have very good eyesight to look up there. So here we go. I've been asked to talk about neurocognitive disorders and HIV. And what I want to do is I want to try and cover this using some illustrated cases. And again, just like Ashish, I'm very happy to be interrupted. I think the whole thing will go a lot easier if I am interrupted freely. I don't mind. I won't be bruised by the process experience. So this is quite simple. This is just PubMed hits with HAND. HAND, it's a good thing we've got the acronym HAND. HIV-associated neurocognitive disorder is a bit of a mouthful. But there are two things I want to point out on this. The first is there's nothing before 2006, and that's because what was needed was a term and a definition that everybody agreed to, and that's how the term HAND was developed. So although there's a lot of information about HIV-associated dementia and other neurocognitive problems, they were given different names, and it was important to bring them under the same umbrella. So that's what happened in 2006, and obviously this is an increasing area of importance of research, because, as has been stated before, patients are living longer and longer, and we expect many to live a pretty normal lifespan now, and therefore they're getting the ravages of age, and that includes dementia. And the big question, and I don't know, we'll have a discussion about it, I don't have the answer, is whether in fact HIV accelerates the process of aging in the brain, whether you have an increased risk of getting dementia, or whether it is the other lifestyle factors like drug use, cocaine use, or whether it's just that we're becoming more worried about the possibility. And we've seen some scans earlier from Ashish showing that you definitely get some abnormalities in late-stage HIV/AIDS dementia. But of course there is also evidence, which I'll go through, that there's a lot of neurocognitive problems that do occur in HIV. And the question is, not all of them get better when you give them very successful art therapy. So there are many questions that we can talk about at the end regarding this. So this is the all-embracing term. It's called the Frascati criteria. AIDS-defining illness right at the beginning was AIDS dementia, HIV-associated dementia, or HAD. Then we recognized people had neurocognitive problems, but still HIV positive, but weren't demented, and that went under the term of mild neurocognitive disorder, or minimal neurocognitive disorder. And then there were patients who were found to be asymptomatic, and this was brought into some sort of objectivity by the use of quite developed neuropsychological testing. And I'll go into this in more detail, but the definition means that you have your neuropsychological testing in 5 domains. If you have greater than 2 domains which show neuropsychological impairment, then you have either a symptomatic neurocognitive impairment if it doesn't interfere with the function of your day-to-day activities, or if it does interfere, then it's called MND, or mild neurocognitive disorder. As I say, I'll go into that, but that basically is how it's split up. So I just wanted to start with an illustrative case about how HIV gets into the brain and its neuroinvasiveness and the pathology it causes. And I'll say right at the beginning that with Ashish present in the room, I can't wing it with any scans. And so where there is a scan, I'll probably say that the neuroradiologist reported it as, to try and excuse myself for not getting it exactly right. But this first case is a 31-year-old. He's admitted with a measles-type rash, fever, high fever, nasty pharyngitis. And 3 days later he has a focal fit, And then he gets status epilepticus, and it just doesn't stop with standard treatment. He has to be intubated, ventilated, IV phenytoin, IV lorazepam, and it does come under control. And in that whole process, the results of his investigations come back, and they show that he's got HIV seroconversion. He has a lumbar puncture. It shows 217 lymphocytes, so typical of the sort of atypical lymphocytic picture you get with a viral meningitis. He had screened for other viruses, and they were all negative. He was treated initially with acyclovir and ceftriaxone to cover the sorts of things that would give you a meningoencephalitis. This is his diffusion-weighted MRI, which shows a lot of edema, a lot of enhancement. And he's treated with the knowledge that he's got HIV seroconversion with zidovudine, efavirenz, and Eluvia, Kaletra over in the UK, and he's given dexamethasone. And that combination, and we'll talk about this later, was chosen because I wanted to use drugs that penetrated well into the CSF. And zidovudine is one of the classic drugs that penetrates very well. In fact, it's the only drug where there's shown to be clinical trial evidence that it improves AIDS dementia. He was found later to have wild-type virus in both his plasma and his CSF, but the patient died after 11 days. He had a post-mortem, he had brain biopsies, and that just showed, and I'm not going to try and describe this, I hope there's not a neuropathologist in the room, but it shows ischemic neuronal damage and widespread necrosis and widespread white matter infiltration. So that's just a case of very severe seroconversion affecting the CNS, with the patient actually dying at the end of it. And that's really an introduction to what I'm showing you here. On the left side, it shows patients who've had parallel plasma viral loads and CSF viral loads when they're seroconverting, to make the point that if you've got a plasma viral load that's increased, you will have a CSF viral load, a couple of logs less, but they go hand in hand together. And when you drop your plasma viral load with treatment, invariably the CSF viral load drops to undetectable as well. Although, again, right at the end, the last case, it's going to be somebody where they seem to have CSF breakthrough but no plasma breakthrough, and we can look into the relevance of that. And on the right-hand side, all I want to make the point there is that HIV produces, the proteins produce a lot of direct effects on the CNS cells and through cytokines. So it's got the genetic makeup to have a lot of effect on the various glial and dendritic cells that are present in the brain. So this is the natural progression. Of course, I can use this, can't I? Where's the... Oh, there it is. So you start with the HIV-infected lymphocytes. They then get through the blood-brain barrier, and you then get infection of macrophages, which are permanently in the CNS. You have your dendritic cells and your astrocytes, which get infected. You then have the possibility of virus going out, and that may be relevant with regard to sudden breakthrough of virus in the bloodstream, with the CNS being a sanctuary site. So you suddenly have escape, you have rebound in the plasma. Could that have come from the CSF? Or is it relevant that you've got a barrier there that means it's a sanctuary site, and although the plasma viral load is undetectable, the CSF viral load has increased, and you're getting neurological symptoms as a result, and neurocognitive impairment. So these are many questions that need answering. Of course, heart has an effect, very effective heart, on the plasma viral load. Does it have such a good effect on the CSF viral load? And is it that we had CSF breakthrough without plasma breakthrough sometimes because the heart doesn't penetrate well enough? And as an example, you know, if you give atazanavir, ritonavir, tenofovir, and 3TC, that is not a particularly good combination for penetrating through into the brain, certainly to the CSF, whereas if you give nevirapine, AZT, and 3TC, that's an excellent combination. So just as an example. What happens in the brain? Well, if you give it time, you'll get pathological change. And here you have some stains, immunohistochemistry stains, and don't ask me exactly what MAP2 is, but it stains up the
dendritic cells, and on the left you have somebody who died who was HIV negative, and you've got stains of his brain, and on the right you've got somebody with HIV-associated dementia. And this has been shown time and time again that the dendritic cells show this beading, and it's also been shown in animal models, and that's classic of HIV-associated dementia. So you are getting pathological consequences of HIV in the brain. And this is a study looking at patients who had HIV who subsequently died, and looking at their neuropsychological function prior to death and how that correlated with the dendritic cell damage at death on biopsy. It's a little bit morbid, but this is in the early days of HIV research, showing the more you were impaired, neurocognitively impaired, the more damage you had to your dendritic cells at post-mortem. So our case has been reported, similar cases have been reported before, although it's not common, although atypical lymphocytes in the CSF with a typical viral meningitis is not uncommon. What could we have done for this person now? Could we have given them an integrase inhibitor? That rapidly reduces the viral load. Would it have made any difference? I doubt it. What about the viral reservoir? I don't think raltegravir, the evidence for it acting on viral reservoirs is very good. What about an R5 inhibitor? The only one we have at the moment is Maraviroc, because when you have seroconversion, it's invariably R5. It has an anti-inflammatory effect, and could inflammation related to a sort of acute iris be relevant here? Certainly, it's very interesting, the drug, with regard to its anti-inflammatory effect. I doubt if it would have made a difference here. High CPE, well, we used a combination with high CPE, which was available to us. So I don't think we could have done much more for this person who just had an overwhelming viral infection which involved his CNS. So all I wanted to do with that case was just to set the scene, really, of how HIV gets into the brain from the word go after your first infection. Yes?
Like you mentioned that high CP is preferable when somebody is having concomitant CNS disease. But do we have adequate evidence that using a high CP drug or those patients who have CNS viral can make the clinical difference?
No, none at all. What I'm saying here is, I predict what a lot of people in the audience will do, is that we still don't have enough evidence to contradict it. And the logical thing is, if you use drugs that don't penetrate into the CSF very well, and you have somebody with CNS disease, that it's possible that that might be the reason they don't get better. If at least you give them the benefit of the doubt, or give the drugs the benefit of the doubt, if you use ones that do penetrate very well into the CSF, like the NNRTIs and the nucleosides, then you are giving that patient the best opportunity of getting drugs there and to get better. So all I'm saying is, with this patient or with somebody who's dementing who presents to you, I would definitely give them penetrating drugs, knowing that the majority of our combinations do penetrate well, but I would always include AZT. Partly because I'm old, and I've used AZT a lot, but in this setting, for a short period of time, a drug in the CSF, I think is very important. You can always switch it so that they won't get long-term complications from AZT.
And what is the CP's cutoff score? Like, if I'm using tenofovir, ampicillin, and atazanavir, ritonavir, then the CP score is around 6.
It's a 6.
Right? But if I'm changing CP from 6 to 8, is it okay?
Well, no, nobody knows. But if you then switch that to, say, nevirapine, AZT, and 3TC, you go up to 10. Yes. So, you've made quite a significant jump. And I think somebody like this, I would probably add in raltegravir just to get the viral load down quickly. And then you're going up to 13. So it's quite easy to double it up. But there is no evidence. And I don't know if you've heard Scott Latondra talk, who's very in favour, who developed this whole system. It's logical that you do this. It's logical, for instance, that we treat HIV when CD4 count is high, but the British are always the same. They want evidence. And that's why we still have our CD4 count at 350, whereas the WHO have said 500. Because the logic is it's going to work earlier. and prevent all that inflammation you get with HIV. So I'll move on now to HIV-associated dementia, or HAD. So this is a Moroccan man who middle-aged, who was an injecting drug user. He stopped in 2006, but still smoking a bit of cannabis, cocaine and heroin. And given I've said that he's got dementia, then all that may be relevant. He's obviously a bit of a drinker, but not too heavy. And he was diagnosed in 2010 as having HIV with a CD4 count of 320 and a viral load that was modest, but at a level you would start treatment. He, of course, missed all his appointments, and he comes back in 2012, and he's low in mood, he's got no motivation, he's got a poor memory, and of course that could also all be due to depression. But he has an unsteady gait, and on examination he has a global pattern of neurological signs with parietal apraxia, he's got Parkinsonian type signs, he's got frontal signs and cerebellar signs. So there's obviously something going on in his brain. His CD4 count's 58, got wild type virus, and his viral load is 88,000. So in this sort of patient, this is what you're going to be doing. You obviously examine them. You'll do the standard labs, check he hasn't got neurosyphilis, for instance, and we're seeing a lot of syphilis now, certainly a lot of meningovascular syphilis, and one case of a gamma looks just like the case that Ashish presented. And a drug screen for this patient anyhow. Imaging, quickly progressing to an MR scan, doing an LP, doing all the tests on the CSF, but including an HIV viral load, which is part of our normal workup. And then doing neuropsychological testing, certainly in somebody like the patient we've got, if nothing else as a baseline, but in somebody who is possibly with asymptomatic neurocognitive impairment or mild neurocognitive impairment, it's important to distinguish the two. So here you've got, and you've seen these sort of scans before, typical periventricular white matter change, but no evidence of any space-occupying lesion that would cause this. You've also got some cerebral atrophy there. So this is quite consistent with the diagnosis of HIV-associated dementia. The CSF, again, is quite typical with a slightly raised protein, a few lymphocytes, and an HIV viral load, which is raised, and all the other pathogens are negative. So his presentation fits completely with the classical descriptions of HIV-associated dementia, with mainly memory loss, unsteady gait, and low mood. And if you look at the tissue, look at the studies that look at tissue loss in the brain, the majority of the tissue loss is in the areas where patients get the majority of the symptoms. So it's not surprising they present the way that they do present. You've got a differential diagnosis, and you've had all these before. The one in the middle is the gamma that was diagnosed. The left is CMV, the right is PML. But these are the sorts of ones that can present with a sort of acute dementia, and one must be wary that there is a differential. It's not just HIV-associated dementia. But more importantly, as patients get older and older, we're worried about Alzheimer's, we're worried about a multi-infarct dementia, and also you've got to consider normal pressure hydrocephalus. So there's a wide differential diagnosis. You know this data, but the availability of heart in 95 transformed neurological HIV. All the opportunistic infections have become much less common, but also HIV dementia has become much less common. This is the big question I posed at the beginning. We know that non-HIV, by the time you hit 90, 50% will be demented. In this audience here, by the time you're 80, 20% of you will have a significant amount of neurocognitive impairment. I'm sorry, folks. The question is, will that be greater in patients who are HIV positive? Will it occur earlier? And this is a great concern to those patients who have HIV. What's the argument for? Well, you get, like you do in Alzheimer's, the classic pathological finding is amyloid deposition. You get exactly the same with HIV-associated dementia, and this is 30 years younger. And the MR changes, of course, are very similar. You've just got a lot of atrophy, which you get in Alzheimer's as you do in HIV. So there's no real difference there. What about improvement? I think this is the great question, because you have somebody who's got neurocognitive impairment. You start them on heart, you get their plasma and CSF viral load undetectable, and they don't improve. But in my experience, patients who come in clinically with dementia, when you start them on heart, actually do get better. So what other evidence do you have? There is evidence, and I'm not going to try and wing it with these these scans that I know very little about, but there is evidence from the literature that there's an increase in the white matter, there's an increase in the inflammatory activity, which may not be good, and there's an increase in metabolic activity after you start treatment. So obviously something is happening in the brain to start everything up again. And I'm always fascinated by the fact that patients with dementia may get completely better. You do a scan and it looks exactly the same. And I suppose you can't expect any change in the volume of the brain tissue, but the function of the brain tissue is obviously working better. So this patient went on to raltegravir, trizavir and Eluvia, which, talking about CPE scores, it's a pretty good going 15, and he simplified to Eluvia and Cavexia, and there was a significant improvement in mental state over the 9 months. And he's now CD4 of 480 with a viral load that's undetectable. So he's done really well, a case of AIDS defining HIV-associated dementia. So I don't know if there's any questions now before we move on to minor neurocognitive disorder, which is the sort of next stage up. I don't know if people's experiences are when you have the severe demented patient that in fact they do really quite well clinically when you start hard, but with the one who's got minor disease you don't necessarily see the same improvement.
Yeah, like we don't have great experience, but the C is probably a major risk factor, like C co-infection for
it is.
associated dementia. So how common, like dementia compared to HIV mono-infected and HIV-HCV co-infected patients?
I think that's an excellent question. We know that hepatitis C can be found in the brain. We know that hepatitis C mono-infection can give you neurocognitive impairment, just like HIV can. We know that in co-infection it's worse than it is either with hepatitis C mono-infection or HIV mono-infection. So the co-infection is just two neuroinvasive viruses doing their work and causing cognitive problems.
So does interferon ribavirin treatment affect or improve the neurocognitive dysfunctions in CD?
Do you know, I think I'm not got the perfect answer to that. I'd have to, discuss it have a look at the literature. I'm sure we know that HIV, it probably does in some patients, and with hepatitis C, if you get a sustained virological response and eradicate the hepatitis C, you'll get it from everywhere. So you'll get it from the extrahepatic tissues like the brain. And so they should get better if there's no damage. And so my guess would be there would be improvement. But chapter and verse on that I'm not going to give you.
Can I ask a question? In my practice, I've seen some HIV-2 patients, having had. Is it really true that HIV-2 has increased incidence of that? Or
I don't know. I don't know the answer to that. We have so little HIV-2 in the UK. There's less than 100 patients in total in the UK with HIV-2. Obviously, it's classically a less aggressive disease in every respect. Certain clades of virus do seem to cause more neurocognitive problems than other clades, and that's a definite fact, like hepatitis C. But whether HIV-2 is more likely to give you neurocognitive disorder, I think is difficult, because the people who get HIV-2 have other handicaps, really. There may be educational handicaps, given where they're likely to have come from West Africa. So, there are other issues that may have a part to play.
So in this case, you initially gave a ART with a high CPS score, and then you reduced it.
Yes.
So what are the parameters? When do we reduce it to lower CPS score? And is there a risk of relapse?
Right, I'm doing this off the seat of my pants. I'm doing what we all do as clinicians, is we manage the patient. There is no evidence that a high CPE score has made the difference. probably just giving Eluvia and Cavexa right from the word go would have made the difference, would have done the same. But you're sort of duty bound to give a higher a combination with a higher CPE score, obviously where the cost of the drugs isn't a barrier. And when the patient has started to get better and their brain is getting better, then it makes sense to reduce the number of tablets so you maintain adherence, because keeping that viral load undetectable is obviously important. So it's, again, logic, evidence for it, none.
How will you manage a patient developing neurocognitive dysfunction and had experience with NRTI, NNRTI and PI? And how will you manage ART in this group of patients?
Well, I think there you've just got to manage the virus, because you need to have that virus undetectable, because if you have a detectable virus in the blood, you will have a detectable virus in the CSF. If you have a detectable virus in the CSF, that's well correlated with neurocognitive impairment. So you'll use whatever drugs you can get hold of. And, you know, that's a situation where if your PI mutations don't prohibit the use of darunavir, boosted darunavir, you use that, and then you'll use raltegravir as a new drug, Maraviroc probably, if it's R5, as a new drug, and etravirine, for instance, as a second generation NNRTI, and make certain the patient takes their tablets. Otherwise, they are really, this is you know, the last gasp for them. They've got to take their tablets. But I mean, going back to the original question, you've got to maintain an undetectable viral load, because otherwise you're never going to win.
When we do the CSF viral load, does that correlate with the virus in the brain parenchyma?
Again, nobody knows. You certainly can find more virus in the brain in people who have neurocognitive problems. It's in the brain, but if you've got somebody who's got neurocognitive impairment who's alive, you can do a CSF very easily, but you can't really stick a needle into their brain to get a good bit of brain to measure the amount of virus in their brain. So it's really just, what a lot of the data we use is from samples that, you know, from before 1995 when people were dying, and they were looking then. And of course we didn't do viral loads then, and so you've got the brain data from before 1995, but not the viral load data, and you've got the viral load data after 1995. But then nobody was dying. So you're kind of making that correlation is difficult. But again, using what I think is reasonable logic, what goes on in the CSF, which bathes the brain, is probably a fair reflection of what goes on in the brain. And if you take efavirenz with its neuropsychological effects, it's got very good CNS penetration into the CSF, and therefore, you know, it's obviously got good penetration into the brain. So I think it's reasonable logic.